Hello, welcome to this session on lifestyle medicine for and self-care for dysmenorrhea or period pain that may be associated with a premenstrual syndrome. I am Justine Bold and I'm the Programme Director for CPD in the Centre for Medical Education, and I work in the postgrad department there, and that's in the medical school, and I'm working on continuing professional development courses. I have an interest in interdisciplinary education. That's where professions learn together. And I do have an interest in female reproductive health, and I have published in that area. I've also got a long-term interest in digestive health and gut malabsorption and food sensitivities and allergies. My background is as an academic lecturer in nutrition at another university where I've worked on a master's course for over 13 years. And I originally qualified as a nutritional therapist. These are some of the publications that I've touched on. And in here, I've looked at integrative management of female reproductive health issues that may impact on fertility. So obviously, some of the secondary causes of dysmenorrhea, like endometriosis, have impacts on women's fertility sometimes. So I've looked at those conditions in more depth in these publications. So I'm interested in how exercise and eating well can affect management of conditions and outlook if people are trying to conceive. And I've looked at that from a male reproductive health point of view as well. So I'm interested in that, but I'm also interested in what happens when you think about, stress management and sleeping well and physical exercise and smoking cessation, alongside maybe introducing some complementary and alternative medicine like acupuncture or yoga as well. So I've published or co-edited a book specifically about supporting assisted reproduction and looking at supporting patients or clients with recurrent miscarriage. And I worked on that with some lovely people, actually. We have chapters on lots of the female health issues, but also male health as well. And we look at things like weight management, smoking cessation, alcohol intake. I've also presented on integrative management and nutrition specifically at pelvic and obstetric gynecological physiotherapy conference, and I wrote that up for their practice journal, which was published, and that article was published in 2017. I have a long-term sort of research interest in celiac disease and gut malabsorption as well, and I published the first case report on non-celiac gluten sensitivity and reproductive problems, and that has been confirmed by other case reports. So that's a kind of new and emerging sort of area for future research to look at. So today I'm going to introduce lifestyle medicine. I'm going to have a brief look at some gender issues and pain. Then we're going to look at dysmenorrhea period pain and the different types. So there's primary and secondary. I have then a quick look at the evidence for some lifestyle medicine approaches that we can kind of use to help us shape sort of self-care suggestions, either for patients or clients, or perhaps for yourself if you're here because you're trying to manage your own health issue. This is a general taster introductory session. I expect it to last for around 40 minutes, so I haven't got a lot of time. Because of the time pressures, when I'm looking at some of the evidence for certain approaches, I'm going to try and translate that into a tip on the same slide. So I will try and give you tips as we go. I am going to be dealing with questions on the Thursday, 22nd of April at 2 p.m. via Twitter, and that's via the university's CPD Twitter address. The handle for that is at the end of this presentation, but you can also tweet to my own Twitter account as well. And I look forward to taking questions. So if you think of anything that you want me to answer, you don't need to wait till the 22nd. You can email, or you can tweet those now, and they will, or email them even now, and we can get them answered on Twitter when I'm actually online. So what is lifestyle medicine? Well, the British Society for Lifestyle Medicine is a society that is trying to get doctors and other healthcare professionals to think about the person who's maybe seeking medical advice in terms of not just them and their conditions, but them and their conditions and their lifestyle, and particularly to think about level of physical activity and exercise they may do, their dietary history and nutritional status, but also how well they sleep, are they stressed, what's their mental health or well-being like, are there any substance issues around, tobacco, drugs, alcohol, and what are their relationships like? Are they living alone? Are they living with people? How are those relationships? How are the family relationships? Because they can impact quite a lot on health. So before I start to bring in some of the evidence for lifestyle approaches in dysmenorrhea, it's worth touching on gender issues in pain. It's a really complex area, and I found this systematic review from 2011. It's actually summarising research on 172 articles. What they are reporting is that hormonal and physiological factors are either inconsistent or absent. So that's interesting. I've looked quite a lot at gender and allergy and inflammation, and there's seems to be a protective effect to some degree from some of the more systematic kind of autoimmune diseases afforded by estrogen. However, it seems to cause an increase in allergies in women when they're of reproductive age, and that gender gap in allergy and immunological kind of terms evens out after menopause, so you lose the protective effect of estrogen. So what this is saying is in pain, it's not so clear cut, essentially. Those hormonal factors are either inconsistent in studies or not a factor. So what they are saying is that there are studies that suggest gender differences, however. This is particularly where intensity of the pain may build with repeated level of the same as well, the stimulus, essentially. So pain at the same level might be felt increasingly more in women. Also, there seems to be gender differences around things that might not normally being considered painful as being considered painful. There's probably a gender difference around pain in surrounding tissues. That's called hyperalgesia. That's where pain is felt in surrounding non-damaged tissues. So what they're saying there is that all of these factors might be more pronounced in women than in men, and that's the results of this systematic review. So they say the evidence to support less efficient endogenous pain inhibition systems in women is mixed. Depression may not mediate for sex differences in pain perception. There's an ambiguous role for anxiety. They're saying that cognitive and social factors may partly explain some sex or gender-related differences, and they may be individual history that is significant in female pain responses, but that actually we still don't fully understand gender and pain differences. It's understudied, essentially. So I thought that was worth introducing before we look at dysmenorrhea in depth. This paper is an earlier paper from 2005, actually says, there's a higher prevalence of chronic pain in women and there's greater pain sensitivity in women, but that's obviously not supported so clearly in the 2011 paper that I've just showed you. So on to dysmenorrhea, which is pain around menstruation. I got this from Instagram, Bella Illustration, so thank you for that. So painful periods, dysmenorrhea, there's two types, primary and secondary. Primary dysmenorrhea is pain around the menstrual cycle, so maybe before, during a period where they haven't found a cause for that pain. It's a very common cause of pelvic pain in women, and obviously it can interfere with daily activities, and that can have a knock-on effect on quality of life. Common medical treatments include the non-steroidal anti-inflammatory drugs and contraceptive pill. So the underlying mechanisms, it's thought that the cyclooxygenase pathway produces increased prostaglandins that cause uterine contractions. This can restrict blood flow and it leads to the production of anaerobic metabolites that stimulate the pain receptors. That's a new, relatively new paper from 2020. In secondary dysmenorrhea, there's actually, a reproductive disease essentially, or cause, and it's caused by conditions such as endometriosis, uterine fibroids or myomas, and adenomyosis as well. This, in the same way that primary dysmenorrhea can impact on daily activities and quality of life, so can secondary dysmenorrhea. And all of those conditions, do have quite big impacts on women. Particularly endometriosis, I would say, from a fertility point of view, and adenomyosis as well. Usually fibroids, unless they're huge, they won't necessarily impact on fertility potential, but they can cause heavy bleeding as well as pain. So again, common treatments are the non-steroidal anti-inflammatories, maybe the contraceptive pill, but they may also use the gonadotrophin releasing hormone, I think it's Agnus medication, things like Zoladex, to effectively induce a sort of cessation of menstrual cycle, so a temporary menopause to stop sort of some of the conditions. So that's used in endometriosis treatment. There's obviously surgical treatments as well for those conditions. So it's it's really interesting to think how much pain is normal around menstruation. Obviously menstruation is slightly taboo. Emma Barnett, the journalist, wrote a book last year or the year before called Period, around, it is a taboo. People don't talk about it much. So for young women, may be very sensitive, still going through adolescence or puberty, they may find it incredibly difficult to talk about. So, how does a woman know when the pain is not normal, particularly if there's difficulty talking about that pain with either family or healthcare professionals, or when a certain amount of pain is normalized culturally around menstruation? I think the degree of uncertainty there, it has caused this sort of a knock-on effect on sort of delayed diagnosis of some of the conditions that can cause secondary dysmenorrhea. So we particularly have had a report on endometriosis in the last few months. It was published at the back end of 2020. It's a UK government report or parliamentary report, and actually it has a really shocking finding that on average a woman is waiting around 8 years to be diagnosed with endometriosis. So this it's a significant problem for us. So dysmenorrhea period pain around menstruation affects around 3/4 of women under the age of 25, so it's a significant issue. There is this cultural kind of normalization around, of pain around menstruation, and actually it might mean that young women are particularly avoiding seeking medical advice or talking to a pharmacist, and actually relying on self-care and over-the-counter remedies like paracetamol. So, and actually that's feeding into delayed diagnosis of some of the other conditions. So the All Parliamentary Group Inquiry Report on Endometriosis in the UK found that women with endometriosis are waiting an average of 8 years for a diagnosis. And that's despite nearly, 58% of them visiting their doctor, GP 10 or more times in relation to their symptoms, 53% visiting A&E, and 21% seeing doctors in hospital 10 or more times. So you can see that that represents a significant burden for primary care and secondary care there. That report was based on 10,000 responses from women with endometriosis. I will talk a little bit more about endometriosis later, but obviously it's a taster session, so I can't go into it in a lot of depth. So premenstrual syndrome, pain is a part of that. So a woman has premenstrual syndrome if she complains of recurrent psychological and or physical symptoms occurring specifically during the luteal phase. That's the latter half of the cycle. So it would be the last 14 days of a typical 28-day cycle, that resolve by the end of menstruation. And it says at the bottom that symptoms are depression, feeling hopeless or guilty, anxiety, tension, mood swings, irritability, persistent anger, decreased interest, poor concentration, fatigue, food cravings, increased appetite, sleep disturbance, feeling out of control or overwhelmed, poor coordination, headaches, aches, swelling, bloating, weight gain, cramps, and breast tenderness. So dysmenorrhea can be a part of having PMS, and that's from a paper on premenstrual syndrome that was published in 2015. So PMS is also very common, affects just under half of women. France in this study reported the lowest incidence. That's interesting if you think about characteristics of the French diet, perhaps. Might give us a few clues. So I've mentioned that oral contraceptives and non-steroidals can be used as treatments to help medicate. Other medication that might be used in PMS include things like diuretics or selective serotonin reuptake inhibitors. There is quite a severe form of PMS called PMDD, premenstrual dysmorphic disorder, so there might be more likely to use some of the antidepressant-based medication in that condition. So what has lifestyle medicine got to offer? Has it got anything to offer? Can food help? Can vitamins and minerals help? Does exercise make any difference? Do other lifestyle factors make any difference? So we would start from a nutritional perspective by thinking around, dietary history, food preferences. Are there any obvious nutritional issues, nutritional gaps, we might call them? How might we plug those gaps if we think there are any? Would we do that with food? Could we do it with food? So there's a 2019 systematic review on that concluded that calcium and vitamin D, either diets rich in calcium and vitamin D or supplements of vitamin D and calcium can eliminate or reduce symptoms of PMS. It also concludes that low calcium and vitamin D in the latter half of the menstrual cycle, that's the last 14 days of a typical 28-day cycle, can exacerbate, that's worsen the premenstrual symptoms. They also conclude that it's inexpensive and low risk. So we tend to like those treatments, especially if they are effective. Now, in nutrition, you're not allowed to treat. You can only support the body's natural healing. But obviously, if you're care professional or medic, you can treat. So that's interesting. Vitamin D is obviously normally made through sunlight exposure on skin. Obviously, we've been in lockdown and quarantine, so people haven't been going outside as much as normal for the last year. That might have had an impact on vitamin D status. And people with darker skin, also higher amounts of melanin in the skin, reduce the synthesis of vitamin D. What we know from the National Nutrition and Diet Survey is that around a third of adults have levels of vitamin D which are indicative of deficiency. So that's below the 25 nanomole per litre. That's the National Nutrition and Diet Survey. Is a really important survey for people who are interested in nutrition. It's a rolling survey that looks at sort of dietary patterns and intake. And it's been rolling since 2008. And they actually do take some physical measurements and blood and urine samples as well. So that data comes from that survey. So vitamin D is really important for bone health. It regulates calcium uptake, has a role in immune function, although our guidelines in the UK are established only on the basis of its functions in musculoskeletal health. So it's very interesting if you look at its role in the immune system. This is an earlier 2009 systematic review that also supports the use of calcium in premenstrual syndrome. Oren, can you go away? Sorry, I've been disturbed again by a little person, so I'm very sorry about that. It also says there's maybe some evidence for chasteberry. That's its other name is Agnus castus, and also vitamin B6. And that they cite in the study that there's preliminary data showing some benefit with ginkgo, magnesium, St. John's wort, soy, and vitamin E. It's worth mentioning actually St. John's wort is a natural remedy, but it can't be taken with antidepressant medication that's SSRI based. So what they say here is only calcium had good quality evidence to support use, and that obviously further studies are needed, particularly RCTs. So if we're thinking about calcium intake, I would always start with food and food sources. This was a double-blind trial that used 500 milligrams of calcium carbonate twice a day for 3 months, so over 3 cycles. And what that showed was that early tiredness, appetite changes, depressive symptoms were significantly improved in the group receiving the calcium treatment. So that's interesting from the point of view of dosage. So they'd looked at 1,000 milligrams, so a gram a day. The recommended daily intake, well, it's recommended reference nutrient intake actually in the UK, it's the RNI, is 700 milligrams per day for women but in the 19 to 50 age group. It's also 700 for the 50 plus age group. So the intake in this study was slightly above the reference nutrient intake. So I just sort of put some illustrations of calcium-rich foods. The green veggies can be quite good, the cruciferous veg, kale and broccoli, but also dairy foods, so milk, cheese. If somebody's not consuming dairy, if they're vegan, that's obviously a big trend for people to become vegan in the UK, then the fortified plant milks, now they would be suitable alternatives now, but not all plant milks are fortified, so you've got to buy a good one that is fortified. Yogurt or yogurt alternatives might also be a source of calcium as well. And you can get calcium from small fish with the bones mashed in, and also foods that include ground up sesame seeds or poppy seeds. They're quite high in calcium as well. So I've highlighted hummus and tahini there as sources of the sesame. I've just tried to give you an illustration of the amount of calcium in food. So you can see that dairy is a very rich source. 1 cup of cheddar there, that's 132 grams, giving nearly 1,000 milligrams of calcium. A tall Starbucks drink made of soya milk will give you 420 milligrams. So you can see that those fortified plant milks can be a good source. In contrast, you can see that actually if you were not having those fortified products, you might have to work a bit harder, because the level in the pumpkin seeds at the bottom there, and that's 1/4 cup, so just under 35 grams of pumpkin seeds, is only 17.6 milligrams. So other lifestyle factors besides calcium and some of the other vitamins or minerals that were mentioned there in the previous papers that might be a factor, and particularly might be a factor for younger women, are things to do with eating patterns. So this study highlights that disordered eating, uncontrolled eating behaviours, and emotional eating might be more associated with PMS. So I know from other reading other studies that adolescents are particularly prone to disordered eating in terms of irregular eating and eating away from home. Obviously, in a normal non-COVID situation where they can go out, they're eating out of home and maybe from convenience outlets, eating on the hoof, as it were. So I would say that what can be really important for nutritional status is having breakfast. And actually, there's quite a lot of data that says where adolescents skip breakfast, they're much more likely to be not hitting nutritional requirements. So having a simple tip to have 3 meals a day and a breakfast, so it can really make a difference. So having regular eating pattern and 3 meals a day, trying to have breakfast, might help in terms of self-care for symptoms. So other lifestyle factors that can be associated with PMS are having higher alcohol intake and poorer sleep quality. So also if there's a family history of dyslipidemia, and so that's interesting as well. So drinking in moderation, not to excess, having regular sleep pattern can all be supportive in terms of lifestyle strategies. This is interesting. I found this on yoga. They said 30 minutes per day, twice a week. So that's 1 hour a week for 12 weeks at home. So again, across 3 cycles. Significantly improved their menstrual pain, physical fitness, and quality of life. So, a specifically designed yoga program may be a possible complementary treatment for period pain. So I wanted to draw your attention to another mineral, magnesium. It's actually a component of chlorophyll and found in green foods as a result. So really good food sources are things like whole grains, nuts and seeds, but also green veg. The reference nutrient intake in the UK for women of reproductive age, so 19 to 50, and also the 50 plus age group, is 270 milligrams a day. Now this is a review article that was published in 2017. Basically, it says around 2/3 of the Western world are not achieving the recommended intake. And there's evidence that supports use in women's health issues, specifically around PMS and migraine. It's one of those supplements that's quite safe at low levels. You don't really get a toxic effect from it. And so it can be used supplementally, but you can also, if you eat the right foods, get your levels up significantly by eating, you know, certain foods. So I've given you some examples there for the foods that can be eaten. So half a cup of pumpkin seeds, so just under 35 grams, can give you 184 milligrams. Half a cup of oats, so you know, oat-based porridge, 138 milligrams. And this is almond butter is next. 50 grams of almond butter could give you 152. Sorry, that would be milligrams there, not grams. I will correct that on the presentation. So other micronutrients that could be significant, and this is I've put in a paper here that's been written from a series of case studies in the journal Medical Hypotheses. So it isn't highest quality evidence. It isn't from an RCT, it isn't from systematic review, it's meta-analysis, but it's interesting. So what they have reported on here is a series of case histories where they have given between 1 and 3 30 milligram doses of zinc daily for 1 to 4 days only before menstruation, and they've seen that this has prevented cramping. That is actually quite a high dose, and we wouldn't necessarily recommend that at all for longer than the 4 days mentioned here, because it is a high dose. But just to give you an example, the reference nutrient intake for women 19 to 50 and 50 plus is 7 milligrams a day. And the amounts in foods, just so you can see, 120 grams of shrimp would give you 2 milligrams. Half a cup of pumpkin seeds would give you around 3.3 milligrams. And 1 boiled egg would give you around 1.4 milligrams. So if you want to have a look at that paper, you can. It's really in there to just highlight the importance of a really good, balanced diet and a varied diet with lots of different food sources, because, you know, poor eating over time will mean generally that somebody isn't hitting the nutritional requirements, and therefore they may not have, you know, a good status of you know, some nutrients in the body. So phytoestrogens, that's another interesting one. And here, this has been used with premenstrual syndrome at a dose of 68 milligrams a day. And it's been shown that was over 2 menstrual cycles, and it reduced the physical symptoms, especially breast tenderness, headache, and cramps, as well as swelling. So obviously you find those soy isoflavones in soya products, so things like soya milk, soya yogurt would be sources, also things maybe like miso. Now, chasteberry was mentioned earlier. Another name for that is Agnus castus. And here, this is a review of 43 studies that was published in 2017. It concludes it's beneficial on pain and PMS, and it works because there's dopaminergic compounds in the plant. So that's an interesting one that people can consider as well. So I'm just going to touch on some of the secondary causes in more depth, majoring on endometriosis because of time. Endometriosis is really common. It affects around 10% of women. So I've seen estimates saying that that's around 2 million women in the UK, or 1.5 million women in the UK. I've seen recently in the press that this reference here says it's around 2 million women in the UK. So it's thought that the cells from the lining of the endometrium migrate, and they migrate to where they shouldn't be, and it can be that they go around the ovaries into the fallopian tubes, but they might also end up on the bowel and bladder. In some cases, I believe they've been found outside of the abdomen as well. So the pain that you get with endometriosis is because the cells that have migrated respond to the hormones controlling the menstrual cycle in the same way. So there can be a shedding of and blood loss, but obviously the blood has got nowhere to go. If it's outside of the uterus, there's no route for the blood to be lost from the body. So this, over time, builds up, forms cysts, and you can get adhesions forming, which can cause a really significant amount of pain around not just menstruation, but also ovulation. Women with endometriosis can have bowel and bladder problems, a lot of fatigue and infertility as well. And it does seem that the endometrial implants are innervated and they produce inflammatory cytokines. So you can see that there's a whole inflammatory cascade there started with, involving things like the interleukins and TNF alpha. The psychology department at Cardiff Uni studies the impact of some of the conditions affecting fertility on women. And I think this has been produced in association with some of the staff from the psychology department, but it's a document actually using images produced by women with endometriosis to describe their experience of living with the condition. You can download the full thing there. But the pain is obviously quite extreme, so you can see that illustrated by the diagrams. So obviously it can impact on fertility, as I've already mentioned. In terms of lifestyle, there is a higher risk that women with endometriosis have a higher risk of having celiac disease than the general population. So if there's a family history of celiac disease in a mum or a sister or a dad, then I would urge those women to see their GP and try to get tested in case that's underpinning their health issues. So what can we do in terms of lifestyle medicine? So I've given you a few tips as we've looked at some of the evidence. Obviously using the 4 pillars that Dr. Chatterjee has publicised in his book, The 4-Pillar Plan, where he talks about what you can do in terms of eating, sleeping, relaxing and moving in terms of keeping well. I think particularly for female health and dysmenorrhea, we're looking at regular meals, 3 meals a day, eating 5 a day, fruit and veg, having the healthy fats, the omega-3s, lots of colours, so rainbow diet, treats and alcohol in moderation, having healthy proteins and whole grains for the fibre. Good sleep hygiene, regular bedtime patterns, time in nature, journaling, enjoying music, moving, exercising, time outside. So the healthy eating guidelines in the UK are based on the UK Eatwell guide, and you can find that usually on Public Health England, probably get it Public Health Wales, and also on the NHS websites. So that's meant to be a diagrammatic representation of the your food for a day in terms of the proportions and guidelines. So you can see about a third of your diet is meant to be the starchy, slow burn carbs. A third is kind of fruits and vegetables, excluding potato, because potato counts as a starch. And then you've got the bottom or the remaining sort of third made up of your proteins, your healthy proteins, your dairy and your fats, which should be more of the healthy fats than the unhealthy fats, with only small amounts of treats and 6 to 8 glasses of fluid in a day. this plate from Harvard in the States is quite a useful model for a single meal. I think sometimes it's quite hard to translate that into a single meal, the Eatwell guide. The healthy eating plate from Harvard, basically saying half your plate needs to be vegetables and fruits, and quarter as whole grain and a quarter as protein. So it's quite simple to follow. And I found in nutrition education and behaviour change that this works well to show people. So it's quite a useful guide. So if anybody's struggling with sleep, you know, getting outside early in the day, avoiding too much caffeine, having a snack that contains tryptophan, which can be converted into serotonin, it can be useful. And obviously those magnesium foods as well. So whole grains or greens, or perhaps even having magnesium salt bath, because that can reduce muscular tension. It's useful for cramping, and you do get a little bit of transdermal absorption. So I hope, I'm really sorry about the interruptions on noise. I hope I have given you a taster for how some lifestyle approaches can support women with dysmenorrhea, and a snippets of evidence and some clue as to the strength of evidence as well. And I hope I've given you some practical tips on how behaviours, health-related behaviours, food-related behaviours, lifestyle behaviours might be changed positively. I hope I've also given you a reminder about the importance of seeking medical advice about dysmenorrhea to rule out underlying causes, such as endometriosis. So I will be on Twitter to take questions at 2 p.m. on the 22nd of April. And you can, if you don't want to wait till then, you can tweet us questions now or email them in. Thank you very much for listening. Bye.